these kidneys, it showed some pyelonephritic changes in the refluxing kidney afterward. Of course, we have to fix drains, and the careful dealing with the drains is quite an art of the young residents, and you have to teach them how to take care of the tubes. We are a subspecialty of tubes. No urologist is clever enough from caring of the tubes. Drains should be kept draining after diversion at least for 5 to 6 days, and it should be removed when it is stopped to drain. We have to fix the suprapubic pulchostomy tube is preferred, especially if you are in not expert hospital and not expert residence. If you leave only a urethral caster draining the pouch and this caster is kinked or blocked or fell down or whatever, of course you are in troubles, of course, because you don't have another window for drainage of this pouch. I preferred to fix a suprapubic cystocath with 14 French, siliconized, multi-fenestrated, and I keep it for 2 weeks for nice drainage and irrigation of the mucus during the early period of the follow-up. It is quite sleeping and hypnotic steps, and of course, if the urethral caster didn't work, the suprapubic will work, and vice versa, of course. The stents, either you fix it external stents for 10 to 12 days, coming out from the pouch wall to the abdominal wall. But I would prefer to fix a JJ stent on both. In Germany, they prefer to have a mono J stents and keep it outside. But when the stents are outside, you are obliged to take it earlier than 10 days before the patient leave home. But if they are the JJ stent, you can keep it longer for 6 weeks, and it is quite give more chance for healing of the anastomosis of the ureter and minimize the incidence of stricture and of course of leakage. Urethral caster in my hand, I keep it for 3 weeks. It's preferable, especially in the old age, and should be 20 French siliconized catheter with 12 ml in the balloon, not to have a big balloon volume, because it will raise up above the anastomosis of the urethral anastomosis, and it may have more incidence of the leakage. So 12 milliliter in the urethral catheter balloon is quite good with experience of the last 500 cases. Next, please. What to do when the excessive drainage coming from the tubes? Third day, fourth day, fifth day, the drains is still draining a very big amount of fluid. You have to test if this fluid is serum or lymph or blood or pus or urine. Of course, creatinine content in this fluid will tell you if it is serum or if it is urine. If the leak is serum, of course, have an eye on the serum albumin, because this is expensive of the serum albumin, and you have all the time in the post-operative period to keep the level of the albumin above 3 grams. Otherwise, you go into edema of the tissue, and this edema of the tissue will cause disruption of the suture line with higher incidence of wound problem and healing problem as well, because the edema does not exist only in the abdominal wall or in the legs or the buffness of the eyes. No, edema is in the tissue as well, and it may cut through the suture material. And of course, to minimize this edema incidence, you have to keep the albumin, serum albumin is above 3. Also, you have to keep the hemoglobin level above 10, at least in our Egyptian patient. 10 is a landmark of the sound healing of the wound and of the general status of the patient. Maybe the level could be a little bit higher in European countries. But if the leak is urine by high creatinine content in this fluid, wait a little for extra day. It may stop spontaneously. And you can do KUB, plain X-ray, to see where the drain is. Sometimes the tip of the tube drain may hit the anastomotic site, and the suction mechanism and negative mechanism of the column of fluid in the tube system may drag and absorb more urine and give you more plenty of drainage. So you have to withdraw it a little bit under the screen to make it away from the suture line. Of course, if the leakage is minimal, what does it mean by minimal? It could be around 100, 150, 200 maximum, and you can wait for a couple of days. It can improve with time. But if there is much more leakage of urine after the day number 5, of course, you have to do gravity ascending pouchogram or CT urogram to localize the site of the leakage, either in the urethral anastomosis or from the implantation of the ureter or from the pouch sutures of the body of the reservoir. If the extravasation is minimal, we have to conserve and keep an eye on patent catheters all the time. Shout your residents to stay nights beside the catheters and the drains. Otherwise, you will go into troubles. If you leave the patient for 24 hours without observation, you will find the whole urine comes in the drains and nothing coming by suprapubic tube or the urethra. If significant is very bad and the whole leakage is a big amount every 24 hours, you can do nephrostomy tubes one by one and repeat the study every 5 days. And in the vast majority of cases, up to 95%, it goes with conservative management without need for exploration, of course. And you have to tell your patient that this is a matter of time, and if everything will go nice, inshallah. Next, please. This is our early results in 7,000 patients over the last 30 years. Hospital mortality is 3 per 1,000. Minor complication is 23%, major is 7%. Deep vein thrombosis, because we regularly give low molecular heparin for 10 days at least and up to 1 month in high risk patients. Pulmonary complications in 4%, and wound problems in 6%. GIT problems is 4%, and average hospital stay is 12 days because we keep the patients longer than needed because the hospital is a non-profit hospital, and the vast majority of our patients are living in rural areas. There is no health providing system that adequately take care of the catheters, and many patients are illiterate, so we keep the patient in the hospital for safety rather than to make a sort of we have to tell the others that the hospital stay is 7 days and minimal invasive techniques is 3 days and all this. We don't like that. So we have to keep the patient till we make sure that he will be safe at home, not necessarily to have a couple of days earlier or not, because the insurance system and the governmental hospitals will cover the cost. And of course, but maybe in the States or in other hospitals, when they are looking for the cost, I think it is not a matter in our hand, at least in this case. Next, please. Pouch training is quite important, and we have to counsel the patient. Then when we take the catheter out, he has to follow up some schedule of training of the pouch. The pouch is still too small. The capacity now is 50 to 100 milli because it's always drained by the catheters, and it takes at least 6 weeks to become mature pouch. This maturation of the reservoir is by intermittent voiding. Of course, we ask the patient to go to the toilet in the first week after 2 hours, and practice Valsalva maneuver to completely evacuate the reservoir. Second week after 2.5 hours. Third week we increase consequently half an hour till they reach to 4 hours interval between each time to go to evacuate the reservoir. Of course, the continence immediately will be at 50% of patients in the first week, especially if the patient is young. Continence is increasing by 10% each week from the follow-up. At the 6 weeks, 80 to 90% of patients, bifadlillah, is continent in these techniques. Nocturnal continence, a little bit delayed. At 3 months, it would be around 80% of cases. And the early recovery of the continence depends on many factors, including the age, surgical skills, the violation of the stump of the urethra, the capacity of the reservoir, the intellectual capacity of the patient and his intelligence, the diabetes mellitus, and patient compliance. All these are added factors also in this issue. Next, please. Late follow-up, of course, after over years, showed us that there is some inherent deterioration of the kidney function by 4% every 5 years of follow-up, which is a matter of aging of the kidney function. Mucus problem does not exist in our material if you keep to the 45 centimeters, except in 3%. The incidence of stones in these 7,000 patients is around 7%, provided that there is no staples now, no more stones if we stop to use the cook pouch technique. Metabolic acidosis needed admission to the hospital less than 2%. Infections like in the pouchitis or upper tract is around 7%. And the patient who needs CIC to clean intermittent catheterization is around 11%, and the vast majority of them are in females after the first year of follow-up. Hematuria is around 4% and usually microscopic or gross hematuria, and we have to look for infection, stones, or recurrence of the tumors, as well as a portal hypertension. We have a few patients when they have hepatic fibrosis, because the venous drainage of the pouch is to the portal vein, of course. When there is a fibrosis of the liver and the pressure inside the portal vein will be high, so this venous pressure will exert a sort of varices in these pouches. And we had an experience of 4 patients with terrible hematuria secondary to rupture of the varices developed from the ileal reservoir due to hepatic fibrosis. Of course, the prognosis of these patients is not good, and the vast majority of them will die from the hepatic decompensation in addition to the aggressive bleeding. The only treatment is removal of the pouch and conversion into the skin by an ileal conduit or by ureterocutaneostomy. Urethral recurrence, if you have a very good selection criteria in our hands, 2.5%, and urethral recurrence